Thank you very much. After hearing all the presentations this morning, I'm glad I'm just a gynecologist, reproductive endocrinologist. Our issues are much simpler. But I am trained as a reproductive endocrinologist, and I was president of our society back 2 years ago for assisted reproductive technology. So I'm going to talk a little bit about how our society interacts with the federal regulations, as well as how we police ourselves and how we look at our own regulations. And I think this is probably forward. Okay, so in contrast to what I heard this morning, actually it was this afternoon, there were two speakers who mainly stated that ART is an unregulated, or IVF is an unregulated field, sort of the wild west of medicine. And I take issue with that. It certainly is not. In fact, we're probably one of the most regulated fields in medicine. We have state regulations requiring us in our medical boards and our medical licenses, which are issued by the state, requires us to go through medical school and residencies and specialized training and take examinations. Certainly we have federal oversight with the CDC. We all heard about the Wyden Act. The CDC essentially collects data and publishes data on outcomes. So we actually have verifiable or audited data on outcomes of our procedures. We have the FDA, who controls the approval of drugs and biologic products as well as medical devices, as well as for the testing and screening of reproductive gamete donors. There are certain requirements for screening and testing, and it specifies quite clearly how the testing is done and what tests are to be used and to screen donors, as well as if a donor screens positive, what to do with that donor, or that donor cannot be used for gamete donation. So we certainly have a lot of federal oversight in terms of gametes and gamete donation, as well as outcomes data. And we also work with and are regulated by the Centers for Medicare and Medicaid Services by an act called CLIA, which is responsible for ensuring the quality of laboratory testing. So there's a lot of federal oversight in ART. Additionally, our society regulates itself quite strongly. We have a lot of self-governance. We have our specialists have to be certified by the American Board of Obstetrics and Gynecology, as well as the urologist or the male reproductive specialist are examined as well as certified by the American Board of Urology. You must complete, as I said, a residency, a fellowship, take a written examination, take an oral examination. There are CME requirements on an annual recertification exam, periodic re-examinations of oral examinations or written examinations that are performed, as well as the laboratory accreditation, which work with ASRM to accredit reproductive laboratories. We additionally, and I'll mention a little bit about our practice guidelines, our committee opinions, and our ethics guidelines, which our members, by becoming a member, by remaining a member of our society, must adhere to. And our SART, or our society, monitors member clinics for adherence to those guidelines, for adherence to data submission, as well as qualifications of the staff that are performing these procedures. So overall, an overview, this is a highly regulated field. SART and ASRM in the middle. We have oversight of the personnel, the practice standards, and ethics. However, we have accreditation of laboratories by New York State, by CAP, and by Joint Commission. We have licensure and certification of the personnel and facilities, which is by the state in terms of the physicians, the nurses, the lab professionals, as well as the facilities. We have the CDC and the Wyden Act over the Success Rate Certification Act of 1992, as well as the FDA oversight in terms of testing and screening of gamete donors and biologic products. So who is SART? Well, SART was founded in 1985, 7 years prior to that Wyden Act that we were talking about. So even before there was a bill in Congress that required programs to submit their data and look at outcomes data, SART was doing this for about 7 years. It's an affiliate of the Society for Assisted Reproductive Medicine, which was founded in 1944. And our mission statement essentially states that our organization is set up to help maintain the standards of ART in an effort to better serve our members and our patients. SART includes physicians, laboratory technologists and biologists, practice managers, international physicians, researchers, scientists, nurses, lawyers, as well as mental health professionals. Those are for us, not for our patients usually, with all the regulations we have. And our membership requirements are quite strict, in fact. So if you look at what is required for you to become a member of SART, our society. Remember, this is a voluntary organization. This is not mandated. You can do in vitro fertilization without becoming a member of SART. But as I mentioned, SART sets a certain standard, which really sets a pretty high bar in terms of the practice of medicine and IVF. So the medical laboratory director must be members of ASRM. The medical director must be ABOG board certified or eligible, has to have done that specialized training in reproductive medicine. The laboratory must be accredited through CAP Joint Commission of New York State Tissue Banks, as well as the lab director must also be accredited by CAP, CLIA, or New York State Tissue Bank. You must perform a certain minimum number of IVF cycles a year to remain proficient, which is 20. You must submit your data to SART cores. You must meet all the currently published guidelines for minimum standards and adhere to all the published guidelines, and you must sign a statement that you will adhere to all of the ethical, practice, laboratory, and advertising guidelines published by our society and pay a membership dues and per cycle. So every IVF cycle you do, you must pay a fee for. So larger programs pay a larger fee because they do more cycles. If you look at the total number of IVF cycles performed per year, this is going up, and about 150,000 cycles of IVF are performed by SART member clinics. This is about 85% of all clinics are SART members. Not everyone's a SART member. And over 90% of ART cycles in the US are performed by SART member clinics. So it's a huge number of cycles, and it's the majority of cycles are actually members of our organization. It's 391 clinics currently, and about 1% of all births in the US are from ART-related pregnancies or IVF-related pregnancies. So we set the highest standard. We talked about this. We have ethics guidelines. I'll show you a little bit. We have research committee, which provides data for members to do research on. So instead of just having your own clinic data, we have national data over about 15 or 17 years, and you can request data sets which are de-identified to perform research. If you want to look at the effects of BMI, or body mass index, on ART outcome, if you want to look at the effects of race or any other parameter, you can do that by requesting the data sets from our research committee, and they provide that de-identified, free of charge to the clinic. There's no cost. SART pays for that. The advertising committee looks at and really reviews, and I'll show you website reviews, to keep clinics from false advertising. Our QA committee, we have a QA committee which monitors member programs from adherence to guidelines and issues warning letters. We provide financial assistance for poor performing clinics to try and get them up to a standard of care. We assist clinics in remaining compliant with government regulations. We provide the donor screening testing questionnaire. So we show clinics what is required to remain compliant with the FDA requirements for donor screening and testing. We develop standardized consent forms so that the risks of ART are clearly outlined and spelled out with current medical understanding or knowledge in what's in the current literature, as well as what to do and how to, our lawyers crafted this in terms of the disposition of excess embryos. So the patient signs on a consent form what she wishes to do with excess embryos in the event of death or divorce or other situations that occur. So these are clearly outlined, and we provide these standardized consent forms to our members. Wow, this time goes down quickly. Let me go through. We've developed a whole bunch of documents, and certainly one of the documents that I want to show you is our guidelines for the number of embryos to transfer. One of the biggest problems with IVF is multiple pregnancies. So we have clearly, with our guidelines and our members, brought down the incidence, and I'm sorry for the colors here, but the number of embryos being transferred has gone down every single year. These little blue lines here demonstrate the time periods when the guidelines and new guidelines came out, and you can clearly see that although we have very little impact on the twin rate, we have had a significant impact on the triplet pregnancy rate, going from around 15% down to less than 1.5% currently. So we have significantly managed and manipulated our clinics to lower the number of embryos to transfer back. Our success rates are more efficient, and we've reduced the number of multiple pregnancies and higher multiples significantly just with our guidelines and voluntary compliance. So our ASRM also generates documents, and one of the ones that I'll show you is a definition of I'm trying to speak rapidly, and I actually am worse when you try and get your car keys in the car and you're like, I can't get in. I apologize. So definition of experimental procedures, and our definition has brought and caused us some issues, but we've stuck by our guns, and our definition really is that a procedure is considered experimental until published medical evidence regarding their risk, safety, and efficacy is sufficient to regard them as established medical practice. Relevant medical evidence can only derive from appropriately designed, peer-reviewed, published studies performed by several independent investigators, including a description of the methods and materials sufficient to allow access to their or assess their scientific validity and to allow independent verification. And this came into issue with egg freezing. Egg freezing was being pushed by by individuals and by websites and everywhere else, and we did not allow egg freezing to become non-experimental until we had adequate evidence in peer-reviewed published journals that there was safety and efficacy. And it was only until last year that we had the evidence and egg freezing was removed from the experimental label was removed, and that so now egg freezing is no longer experimental because we have the data to support it in terms of safety and efficacy. But for about 5 or 6 years, this was an issue for our society because we refused to remove the experimental label from that procedure. And also, it should not be represented or marketed as established or routine medical practice. Our advertising committee, and I'll go through briefly, monitors websites and advertising. If a website is outside of our guidelines, that program receives a letter, and they must change their advertising or else they will be within 30 days, or else their membership will be revoked in our society. So we review the websites on an annual basis. Any complaints are investigated, and so far every single request for a change in advertising has been complied with because the stick of removing membership has been quite strong. Our QA committee evaluates programs for different parameters, and these change on an annual basis, depending on what our biggest problem is at that point in time. It could be low pregnancy rates, it could be multiple pregnancy rates, and these are what our current problems have been. So we look at programs with low pregnancy rates, triplet rates, or transferring back too many embryos. And those programs that are out of line will get a warning letter the first year. We request a response and an action plan based on the warning they receive. If they have a second offense, they go on probation, they have a mandatory evaluation of their program to develop an action plan, and if there's a third offense, they're reviewed by the Executive Council and possible loss of membership in our society. I'm going to skip through the disciplinary policy because you know that what happens when you don't comply, kick you out of the society. And I'll just go into the Wyden Act for just 1 second. This is 1992. The Wyden Act was supposed to define assisted reproductive technology outcomes mechanisms, and we were supposed to report to the CDC all outcomes data. Well, we found that our reporting was inadequate because clinical practice changed. It used to be, and this is what it looks like, but it used to be that a single cycle of IVF resulted in a retrieval, a fresh embryo transfer, and a primary efficacy, in other words, a fresh pregnancy rate. Excess embryos were frozen, and they resulted in frozen embryo transfers. However, we became more creative and able to freeze embryos. So now you can have multiple stimulations. If the retrieval never results in a transfer, those cycles go unreported. You don't know about those outcomes. So patients who can go through 3 or 4 stimulations, and the intent of the Wyden Act was they want to know what the success rate is per stimulation. Patients can go through multiple stimulations, have a single embryo transfer, and if it's along with a fresh embryo, it can be a primary efficacy, or if it's never associated with a fresh embryo, it can be a secondary efficacy. So we looked at these practice patterns and say, well, IVF is changing. We're doing more frozen embryo transfers. We have to change the way we report our outcomes because patients don't understand. If I go through an IVF stimulation, what's my chance of becoming pregnant from a single IVF stimulation? So we worked with the CDC because remember, this is a federal guideline. You have to, in the federal registry, you have to include changes. We work with the CDC quite carefully, or at some length, so that every single retrieval now counts. So a retrieval, an embryo transfer, whenever that embryo is transferred from that retrieval becomes a primary outcome. Multiple cycles, the denominator is now 3. If you do 3 retrievals, not 1. So we work with the CDC to make these changes. So my last slide, the red light's blinking, got 20 seconds. Self-regulation is critical, but it only works if membership means something. If membership doesn't mean anything, self-regulation is worthless. You have to have good guidelines of practice, and they have to be effective. Interaction with federal agencies is important. We did this with the CDC and the FDA, but it has to be a two-way street. It has to be a bi-directional communication for it to work properly. Thank you.